Good morning. This is a lecture regarding antepartum fetal assessment. So this aims to monitor the fetus inside the abdomen. This is to ensure satisfactory growth and well-being of the fetus throughout the pregnancy. So this will also screen out high-risk factors that can affect the growth of the fetus. So the rationality of antenatal fetal testing is that it will provide information superior to that to clinical evaluation. And this will be helpful in your management to improve perinatal outcome. The benefits of the test must also outweigh the potential risk and cost. So for clinical evaluation of the fetal well-being, so during the first visit, we're going to check the size of the uterus. This will help estimate the correct duration of gestation. And on the subsequent visits, the maternal weight gain, blood pressure, the size of the fetus, and the fetal height. For fetal movements, passive, unstimulated fetal activity usually at around 7 weeks, and this becomes organized at 20 to 30 weeks of gestation. The fetal movements maturation until 36 weeks, the behavioral states established. So there are 4 behavioral states. We have the state of 1F. This is the quiet sleep or the quiescent state. 2F is frequent gross body movement, continuous eye movements with wider oscillations on the fetal heart rate. The state 3F is continuous eye movement in the absence of body movements and no fetal heart rate accelerations. The state of 4F are vigorous body movements, eye movements, fetal heart rate accelerations, which corresponds to the awake state. And the mean length of the quiet or inactive state is 23 minutes. So in clinical application, we have the Cardiff Count 10 formula. Report if less than 10 movements occur in 12 hours on 2 successive days, or no movement perceived even after 12 hours in a single day. Daily fetal movement count. There are 3 counts each of 1 hour duration on morning, noon, and evening. If less than 10 in 12 hours or less than 3 in each hour. For the fetal breathing, these are chest wall movements are discontinuous in fetus. These are paradoxical chest movements. So more than 1 episode lasting for more than 30 seconds. There are 2 types of chest wall movements. There's sighs or gasp, 1 to 4 per minute, and irregular burst of breathing of 240 cycles per minute. So in a fetus, it's usually a paradoxical chest wall movement in which the chest wall paradoxically collapses and the abdomen protrudes. During expiration, the chest expands. So this is usually different from adults. So we have a parameter, the biophysical scoring. This is also an antepartum assessment in which in the BPP, these are the components. So the non-stress test, fetal breathing, fetal movement, a fetal tone, amniotic fluid volume. In the non-stress test, you will give a score of 2, meaning the baby is okay. If there are more than equal to 2 accelerations of more than equal to 15 beats per minute, lasting for more than or equal to 15 seconds within 20 to 40 minutes. If ever there's only 1 acceleration in 20 to 40 minutes or none, the score is 0. For fetal breathing, it's more than equal to 1 episode of rhythmic breathing that's lasting for more than equal to 30 seconds within 30 minutes. If less than 30 seconds, within 30 minutes, you will give a score of 0. For fetal movement, there should be 3 or more discrete body or limb movements within 30 minutes. If less than 3 discrete movements, the score is 0. You will give a score of 2 for fetal tone if more than equal to 1 episode of extremity extension and subsequent return to flexion. If there's no extension or flexion, the score is 0. And to complete the BPS scoring of 10 over 10, a pocket of amniotic fluid that measures at least 2 centimeters in two planes perpendicular to each other. So by 2 by 2 pocket, it should have a normal value. So it should be 5 to 25. The largest single vertical pocket, the largest, if we're going to measure the SVP, the normal is 2 to 8. So if it's less than 2 centimeter, the score is 0. If we're going to use the amniotic fluid index, the AFI, the normal is 5 to 25. If less than 5, so it's abnormal amniotic fluid index. If it's more than 25, it's also polyhydramnios. It means that the amniotic fluid index is also high. The interpretation of the biophysical score, if you have a 10 over 10, it means there's 2 points in each parameter. So the perfect score, it means that the fetus is normal and non-asphyxiated. And there's no intervention needed, but you just have to repeat weekly, except in diabetic and post-term patients in which you're going to do the BPS twice weekly. If the score is 8 over 8, but you have a normal amniotic fluid value, amniotic fluid index, or the SVP, there is no fetal indication for intervention. You just have to repeat testing. If it's 8 over 8, it means usually it's not 10 over 10, but it's still a perfect score because NST is not done. It's also normal. So you don't have to do anything. If you have a score of 8 over 10, and the one that's 0 is your amniotic fluid index, you have a chronic fetal asphyxia, so you have to deliver the baby. If your score is 6, it's possible fetal asphyxia. So if the amniotic fluid volume is abnormal, you have to deliver. If normal fluid at more than equal to 36 weeks with a favorable cervix, you're going to deliver. If less than 6 on repeat test, you have to deliver. If the repeat test is more than 6, you have to observe and repeat per protocol. If you have a score of 4, it's probable fetal asphyxia. So you have to repeat testing the same day. If the biophysical score is less than or equal to 6, you have to deliver. If 0 to 2, it's certain that there is fetal asphyxia, so you have to deliver. The amniotic fluid volume, so there is decreased uteroplacental perfusion that will lead to a decreased renal blood flow. Therefore, there is a decreased urine production that will lead to oligohydramnios. So the amniotic fluid index, the AFI of less than 5 or a maximum deepest vertical pocket of less than 2, the DVP, the deepest vertical pocket, or the single vertical pocket are the same. So it's if less than 2 centimeters, there is oligohydramnios. It means that there is less water already in the amniotic fluid. Another test is the contraction stress test. So this will measure the fetal response to transient reduction of fetal oxygen during every contraction. In every contraction, there is decreased oxygenation towards the uterus. So if the baby is stressed during a contraction, usually this can be perceived as decelerations. So this is a test actually of uteroplacental insufficiency. So you're going to try to induce contraction by using oxytocin, or even nipple stimulation can also be used. If there's a deceleration during a contraction, you will have an abnormal contraction stress test. So this is the interpretation. So a negative, it means that even there's a contraction, there is no late or significant variable deceleration. A positive CST is that there is late decelerations following 50% or more of your contractions, even if the contraction frequency is less than 10 minutes. So if you have 50% of the contractions even in a 10-minute strip, and then you have late decelerations of 50% in your contractions, it's a positive CST. It's equivocal, meaning you are suspicious if ever intermittent late decelerations or significant variable decelerations, if it will not comply the 50% of your late decelerations. It's hyperstimulatory, meaning the fetal heart rate decelerations that occur in the presence of contractions more frequent than every 2 minutes or lasting longer than 90 seconds. It's unsatisfactory if you don't achieve 3 contractions in 10 minutes. So you have to stimulate more to achieve contractions. That's at least 3 contractions in 10-minute tracing. Your non-stress test is you're going to do this without contractions. So this will test the fetal condition. The fetal heart rate accelerations in response to fetal movement. So usually in a fetal movement, you will see accelerations. If your baby is awake and moving, you will see it as accelerations in your non-stress test. So non-stress test, it means it doesn't have contraction, but you have your acceleration. Your patient is not in labor. So the National Institute of Child Health and Human Development defines the acceleration if more than 32 weeks, 15 beats above the baseline lasting for more than equal to 15 seconds. If less than 32 weeks, it's 10 beats above the baseline lasting for more than equal to 10 seconds. So a normal NST is that you will have 2 or more accelerations that peak at 15 beats above the baseline for more than 15 seconds in a 20-minute reading. So in your CTG, in your strip, you will have 2 accelerations, even that has no contractions in your 20-minute strip. In more than 40 minutes tracing is required to conclude that it's insufficient fetal accounting to sleep pattern. So if ever you don't have any accelerations for a 20-minute reading, you have to extend your trace to 40 minutes to cover for the fetal sleep pattern. So 90% or higher false positive rate. So an abnormal NST or abnormal non-stress test is the fetus is non-reactive for 90 minutes. So this is 90% associated with perinatal pathology. So if you extended your trace already for 90 minutes and still it doesn't have any accelerations, it's an abnormal NST. And 90% is associated with possible fetal pathology. Baseline oscillations are less than 5 beats per minute. So it means you have a minimal variability. You have absent accelerations. You don't have accelerations. You have late decelerations with your uterine contractions, or you have variable decelerations. If not non-repetitive or brief, this does not indicate fetal compromise. So it must be repetitive. Repetitive variable decelerations, at least 3 in 20 minutes, lasting for more than 1 minute, is you're going to suspect that the fetus is already not doing well inside. So when are you going to do these assessments? So it should be twice weekly for women who are post-term, so 42 weeks and beyond, with multi-fetal gestation, twins or more, type 1 diabetes mellitus, fetal growth restriction, and gestational hypertension. Basically, your high-risk women will have a twice weekly assessment. What about your Doppler velocimetry? So your Doppler, this is measuring of the 3 fetal vascular circuits. So these are the umbilical artery, the MCA, the middle cerebral artery, and ductus venosus are assessed. This will aid in decision to interfere in growth-restricted fetus. What are acoustic simulation tests? So acoustic simulation tests, these are, you're going to provide something loud, or you're going to provoke the heart rate of the baby to produce acceleration. So usually you have commercial available acoustic stimulator, and the stimulus is 1 to 2 seconds. It can be repeated up to 3 times for up to 3 seconds. So you're going to wake up the baby. If the baby is sleeping, you're going to stimulate your accelerations. So positive response is defined as rapid appearance of acceleration following the stimulation. Sometimes we do this in the labor room. We're going to provide a loud music towards the tummy of the mother to provide accelerations. So these are the recommendations for antenatal testing. The majority of high-risk pregnancies, it's recommended to start between 32 to 34 weeks. And pregnancies with severe complications might require testing as early as 26 to 28 weeks. And the frequency of testing is 7 days. Okay. So the rest of the antenatal testing, I've covered mostly of the important stuff, and you have to read your book, your Williams, to for the other antenatal testing. Okay. So that's it for my lecture.